X-rays today and how to read and interpret those chest X-rays. That is what we'll be discussing here. Whenever we get these chest X-rays done, obviously we are dealing with adult medicine here, so I'll be discussing the chest X-rays related to the adult patients. The techniques which we use, the technical details which you guys are going to see before you will be commenting on the problems, whatever you will be identifying on the X-rays, that's the most important thing you need to focus on first. Never ever comment on an X-ray before you are well aware about the technical details. To remember these technical details, remember a mnemonic with the name of PREV, P, R, E and V. Or otherwise, remember a sentence. Please remember easy and valuable ways to describe chest X-ray. So please ka P, remember ka R, easy ka E and valuable ka V. So please remember easy and valuable ways to describe chest X-ray, or remember the mnemonic PREV. Here P is for position, R is for respiration, like in what phase of respiration patient is, whether the patient is in inspiration phase or expiration. Then E is for exposure and V is for view. So we'll be focusing on 4 technical details first, and only then onwards I'll be telling you how to interpret X-rays in the most easiest ways. Position. So if you want to know about the position, whether this is appropriate or not, what you are supposed to see. You are supposed to see this is clavicle, this is spinous process, this is medial end of the other clavicle. What you are supposed to see, you are supposed to see whether this spinous process is falling right in the center between these two clavicular ends. So if from the medial end of clavicles this spinous process is equidistant, we'll be saying that X-ray has been taken in appropriate position. There are few other points, but I'll only be highlighting the important ones here, which are considered gold standard as far as X-ray studies are concerned. So this is how you would be seeing the position. The second thing is respiration. I'll be telling you the importance of these 4 technical details as well. The second thing is then PR, respiration effect. Whether X-ray has been taken with proper inspiratory effort or that has been taken in the phase of expiration. If X-ray has been taken in good inspiratory effort, you should be able to see anterior rib number 5th, 6th or 7th bisecting the mid of diaphragm. So what I mean by that? This is anterior rib number 1, this is anterior rib number 2, this is anterior rib number 3, this is anterior rib number 4, this is anterior rib number 5, this is anterior rib number 6. So 6th one is bisecting the mid of diaphragm here. That's very appropriate. Now if this anterior rib number 4th is bisecting the mid of diaphragm, either the X-ray has not been taken with good inspiratory effort, or the volume of lung on that side is reduced. If a patient is having hyperinflated lung, then what will happen? Anterior rib number 8th and onwards will be bisecting the mid of diaphragm. So that X-ray will be taken as hyperinflated. If 4th is bisecting, there can be reduced volume due to some disease process, or X-ray has not been taken with proper inspiratory effort. Point number 3, that is exposure. Whether X-ray is underexposed or overexposed, how you will come to know. In a very beautifully exposed X-ray, 1, 2, 3, 4, these spinous processes above the heart shadow and the vertebra above the heart shadow are visible, in particular the spinous process. The vertebra behind the heart will be just visible. So if you guys visualize these vertebra, which you are seeing here, right behind the heart, you can comfortably see that they are just visible. If they are too much visible, then it will be taken as overexposure. And if they are not visible altogether, this will be taken as underexposed. So an X-ray can be overexposed, the things will be too black. The X-ray can be underexposed, the thing will be too white. And then the fourth point is view. View is, one is AP view and the second one is PA view. PA view and AP view, how you will come to know after seeing these X-rays. In AP view, the scapula will be overlying the lung fields. Scapula will be overlying these areas. This is what we call AP view. And what is a PA view? A PA view is the view where scapula is on side. So you can see this is a very beautiful X-ray where scapula is on sideways. So obviously, for all practical purposes, if you want to see the lung detail, what kind of X-ray you would be looking for? You would be looking for X-ray with a PA view, because in PA view, scapula will not be overlying the lung fields, right? Remember, these technical details are very, very important. The first one, position. Position is not appropriate. Now, what will happen if these technical details have not been seen properly? Position is not appropriate. The X-rays nearly almost always are taken for all these details in PA view. A person is standing tilting on one side or tilting on another side. What will happen? Simply with that tilting, the heart can be tilted to the other side. The mediastinum can be tilted to the other side, and you might find an impression on X-ray that there is a mediastinal shifting or widening, or probably the heart size has been increased. So your findings will not be correct. Problem will be the technical detail in the background. So please make sure position is appropriate. Respiration. If X-ray is taken with poor inspiratory effort, what happens? The bases of lungs turn hazy. These are the bases of lung. These will turn hazy. You might develop an impression that probably there is some opacity there. So this is very important, that a patient should have an X-ray with proper inspiratory effort. The second thing, the second abnormality which occur in that setting is the heart seems enlarged. If we push these diaphragms here, what will happen? There will be an impression that heart is enlarged. So one thing, position. Second is respiration. I have told you what bad will happen. The third thing is then exposure. Whether X-ray is underexposed or whether X-ray is overexposed, what will happen then? Overexposed X-ray. The things are now very much black. If things are very much black, what will happen? There was an opacity here, there was a whitish opacity here. That was due to some disease process. That was a coin lesion. That was some metastasis due to malignancy. If we make things too black, what will happen? That opacity might not be visible altogether. So remember, you may miss an opacity if X-ray is overexposed. And then what can happen if the X-ray is underexposed? The things become too white. And why you see white things in this X-ray? These are vessels. This is vascular marking. This X-ray is a high quality X-ray, very good quality X-ray. Exposure is very good, position is very appropriate, everything is fine. This is up to the mark X-ray. So you are seeing the vascular markings, small vascular markings every here and at different points. Now, if the X-ray will be underexposed, the things become that white that sometimes these vascular markings jumbled up and you develop an impression that probably this is some sort of non-homogeneous opacity. So unnecessarily, you can pick certain things as opacity which will not be actually opacity. And exactly vice versa, you will be missing an opacity if you make things too black. And how you would come to know that things are too black? the whole vertebral bodies will be visible behind the heart. This is too black, overexposed. No vertebra visible behind the heart. This is underexposed. The fourth technical point. The fourth technical point is view. AP view and PA view. I have already told you, if the view will be AP, I am standing like that. From here, the X-rays are coming, passing through my body. As they are passing through my anterior surface first, so these are known as AP view X-rays. If I am in that position, as the rays are passing from my backside first, so this is known as PA view. So in AP view X-ray, the scapula will be overlying the lung fields. You won't be able to see the details. So please remember, these four technical details should always be seen first. Only then you would be describing rest of the details of X-ray. And again, I'm telling you, there are few other points, but these are considered the gold standard points to label some X-ray as technically correct X-ray. Now we move on. Now I have to, rather moving towards that particular point, I would just like to highlight one thing more, that you want to know which one is the right side and which one is the left side of X-ray. So how to know that? 5 landmarks are there. Remember those 5 points. Major portion of the heart is towards the left side. Diaphragm is 1.5 to 2 centimeter above on the right side. Major portion of the heart is on the left side. Diaphragm is 1.5 to 2 centimeter above on the right side. The third point, aortic knuckle is on the left side. Point number 4. It is mentioned and labeled on X-ray which one is the right side and which one is the left side, but not necessarily always. Point number 5. Gastric bubble shadow is on the left side. If a person is obviously not having major visceral changes, that one viscera is on the other side where that was expected to be on that particular side. So always remember 5 points. Major portion of the heart on left side, aortic knuckle on left side. Then the third thing is diaphragm is above on the right side. There is gas bubble shadow on the left side. And then obviously it is written on the X-ray. So sometime there might be confusion. Keep on finding different points and then you will be able to reach to the conclusion. Again, before focusing on to the next thing, I would like to clearly highlight this fact, and you should have that thing very clear in your, you should be very clear in your mind, that whenever you are going to give any finding on chest X-ray, you will always be describing these findings on the basis of the zones, not on the basis of anatomical landmarks. Like you won't be saying that there is an opacity in the right lower chest, there is an opacity in the right infraclavicular region. This is for clinical examination. When you are describing the X-rays, you would be commenting like that. This is the first anterior rib, this is the second anterior rib. Above these 2 ribs is upper zone. Below the second rib is middle zone. Second rib and third rib is middle zone. From where the 4th rib start, the part below the 4th rib is known as lower zone. So there are 3 zones in both lung fields. Lobes are different. Lobes are 3 on this side, 2 on this side, but talking about zones, and we are going to talk about zones only and only zones. Whatever finding we'll be seeing here, we'll be commenting that this is appreciable in the upper zone, this is in the middle zone, this is in the lower zone. So this is all about technical details, this is all about zones, and this is all about identifying correctly the right and left side. Now we focus and now we move on to the major thing, and that is you want to see each and everything. You do not want to forget anything. For that purpose, what we are supposed to do, you just need to remember one mnemonic: A, B, C, D, E, F, G, H. It's such a simple mnemonic. A for airway, B for bone, C for castiophrenic shadows, angles and cardiac shadow, D for diaphragm, E for equal volume, F for fine details, G for gastric bubble shadow, H for hilum. So number 1, A for airway. This is airway. you can see this airway. In a normal patient, in a normal X-ray, that will be almost in the center, or that might be slightly deviated to the right side. That is airway. B for bone. What you are supposed to look in the bones, you are supposed to look for some lytic lesions. You are supposed to look for some indentation in the lower part of bone, maybe secondarily to coarctation of aorta. There might be some fracture here. So these are sort of findings. There might be some osteoblastic lesions. A bone may become too white, a single bone, as it is taking up some signals due to maybe some underlying malignancy. So you would be seeing these bones. 3. Castophrenic, cardiophrenic. Where is that angle? This is casto, this is phrenic diaphragm. So this angle is castophrenic. This is heart, cardio, this is diaphragm. So this angle is cardiophrenic angle. So we are seeing here cardiophrenic angle, this one is, and we are seeing here castophrenic angle. One should be clearly seeing these angles, because in these angles there may be fluid collection, and that is mostly secondarily to pleural effusion. Then we are talking about cardiac shadow. This is the cardiac shadow. Clearly the landmarks have been described very beautifully. It has been picturized beautifully. You can see the whole cardiac border. D for diaphragm. Diaphragm is 1.5 centimeter above on this side in comparison with that side. E for equal volume. E for equal volumes. One need to understand, when you want to see the equal volumes, just look at this area. This one and this one is exactly at the same level. And then look at this point. The upper apex is exactly at the same point. So upper apex, same way, that lower angle, both things are at the same point. So if you want to see equal volumes, you are always supposed to look for these particular areas. Okay, so coming back again, the next is, then you just keep on moving a little bit every now and then so that the picture would remain stable. The next is G for guessing. Again, show the same X-ray. We are not finished yet. A, B, C, D, E. E is equal volume. F is fine details. Fine details is the most important aspect in an X-ray. Most important aspect, because it contains everything. Everything. Other than this A, B, C, D, E, G and H. Everything else is fine detail. So if you are seeing some opacity, this is fine detail. You are seeing some bulla, this is fine detail. You are seeing some cavity, this is fine detail. So everything else otherwise are the fine details. G for gastric bubble shadow, it is there because that helps you to just reach to that conclusion that whether the X-ray, this is the left or the right side. And H for hilum. What is hilum? Hilum is a part of the lung from where the vessels enter and leave. So this is hilum. And where it lies? It lies between second rib and fourth rib. This is second anterior rib. Here it ends. And this is the fourth anterior rib. Here it ends. It lies in this area. So what can be the problems you can see? A, B, C, D, E, F, G, H. Why we are supposed to focus that way on X-ray? That way we won't be forgetting anything. But if somebody asks you to comment on any problem in the X-ray, then your comment shouldn't be like that you just keep on saying A for airway, airway normal, B for bone and bone normal. You would be commenting like that. Sir, this is chest X-ray, PA view, taken with good inspiratory effort, with proper position and exposure, showing a homogeneous or non-homogeneous opacity involving right upper zone, middle zone, lower zone, left upper zone, middle zone, lower zone. So this is how you speak the first sentence. Chest X-ray, PA view, taken in inspiration with proper position and exposure, showing a homogeneous, non-homogeneous opacity involving right upper, middle zone, left upper, middle zone. So your description would be in that particular way. Now move on. Now we would be focusing on certain X-rays, and we would be seeing, based on what we learned till now, that what are different sort of problems. I would be sharing with you some of the common X-rays, and then we'll be discussing those X-rays. Move ahead. Move ahead again. Again, move ahead. Move ahead. Again, move ahead. Okay, just stop there. So what we are seeing here, this is chest X-ray, PA view, taken in inspiration with almost appropriate effort and slightly badly positioned. There seems to be slight tilt toward one side, and what it is showing? It is showing a homogeneous opacity involving right upper and middle zone. A homogeneous opacity involving right upper and middle zone. And this opacity is having something very special in it, which make picture very clear. Because if that thing is there is just one thing that present that way. So as you are seeing this opacity, you are seeing these small blackish air pockets inside. In a whitish opacity, if you ever see blackish air pockets, these are known as air bronchograms. So in an opacity, if you ever see air bronchogram, this is consolidation until unless proved otherwise, and you really won't be able to prove otherwise. So that will essentially be consolidation. That consolidation can be pneumonia, tuberculous pneumonia, that can be viral pneumonia, that can be tuberculous pneumonia, but this would be consolidation, right? Move ahead. So just read what the radiologist is interpreting here. Homogeneous opacity with air bronchogram of upper zone of right lung suggesting right upper lung consolidation. And DDs are, it may be pneumonia, it may be tuberculosis, it may be consolidation associated with neoplasm. At least we cannot obviously clearly identify the neoplasm here. Move on. Move on. So what we are seeing here, that there is an opacity in which zone? In lower and middle zone. So there is an opacity in the lower and middle zone. This opacity is attached with this heart border. Can you differentiate this opacity from this heart border? Nobody is able to differentiate. And if you are not able to differentiate opacity from the heart border, this is a sign known as Sillett sign. A Sillett sign indicates us that there is something merging with the heart border, then you just cannot differentiate those two things. And if this Sillett sign is present in this zone, it is suggestive of middle lobe opacity. So it is usually the middle lobe which mask this border, right border of the heart, and suggesting that this is a consolidation along with the Sillett sign. Just move ahead, read the things so that you would be coming to know about this. There is opacity in the right middle to lower zone, medially with Sillett sign of right lung border, suggesting right middle lobe pneumonia. So if that opacity involves the right middle lobe, it can hide, it can obscure the right border. We consider it as Sillett sign positive. That Sillett sign can be seen in the other lung as well, on the other border of the heart. Wherever something will be obliterating the border of the heart, this sign is known as Sillett sign. Move ahead. Keep moving. Keep moving. Keep moving. Okay. So can anybody comment on that? Anybody? Where is the problem? First, identify where is the problem after seeing obviously the technical details. So I assume that you have seen the technical details. I assume here. So where is the problem? Left lung or right lung? Left lung. Now, if the problem is in the left lung, is it in the upper zone, middle zone, lower zone? The problem is the mid and lower zone. What is the problem? The problem is there is air fluid level. As there is air fluid level, so what it can be? It can be abscess. But can it be hydropneumothorax? Obviously, it can be hydropneumothorax. If that opacity is through and through, exactly up to this costal part, then what it will suggest? It can be hydropneumothorax, but here we are not able to see it beyond that point. So the chances are more that this is obviously lung abscess. If somebody asks you, would you like to get another radiological imaging in the form of chest X-ray in this patient, which can help you to decide whether this is lung abscess or whether this is hydropneumothorax, what you will do? Lateral view. As you will be seeing the lateral view abscess is a circumscribed thing. From the other viewpoint, you would be able to see it. If this will be hydropneumothorax, there would be complete line bisecting the whole lung, right? Go ahead. See what is being described here. A cavity with air fluid level in mid and lower zones of left lung suggesting lung abscess. Stop there. Stop here. What is the definition of cavity? For a cavity, it is necessary that it should have 70%, at least 70% of its wall should be there. So even if it's not 100%, at least 70% wall should be there, right? One thing. Second is it should be thicker, 5 mm or more thicker. So if something is 2 mm, 1 mm thin, what you call it? Bulla. You call it bulla when it is hairline. You call it cavity when it is thick. A cavity is having nothing inside. You call it a simple cavity. A cavity is filled with pus here, fluid here. You label it as lung abscess. A cavity can have few other things inside, as we'll be seeing in the next X-rays. Move ahead. Again, now you can clearly identify a cavity. It's a thick wall cavity with air fluid level, classical air fluid level. So there is highly likely this patient is having lung abscess in his left upper end, middle zone. And are there any satellite lesions around this lung abscess? I mean, there are very few. What are these satellite lesions? Whenever you are seeing a cavity in a certain person, you should have a good idea of the satellite lesions. A satellite lesion is basically kind of non-homogeneous or homogeneous opacities around a certain cavity. Because why a cavity is formed? There is a problem. There is an infection in the lung. This infection is destroying the structure of the lung. What will happen next? When there will be structural damage, ultimately there will be a formation of a certain cavity. If that infection was tuberculosis, if that infection was pneumonia, there will be homogeneous and non-homogeneous infiltrates. And with those surrounding infiltrates, you are finding a cavity, you label it as a cavity with satellite lesions. So there are infiltrates, infective focuses which damage the lung. Made a cavity, few of the infiltrates are around, you label it as cavity with satellite lesion. So that highly suggests that cavity is not secondarily to malignancy, because cavity can be secondarily to malignancy as well. So satellite lesions importance is actually in relation to that particular fact. If somebody ever asks you this question, there is a cavity, what are your differential diagnosis? The differential diagnosis include, one is malignancy. So that's the importance of the satellite lesions. Next. Next. Go ahead. Go ahead quickly. Okay, just stop here. What we are seeing here, can you identify the problem? Which lung is having the problem? Left lung. Where is the problem? Obviously, you can identify here is the problem. What is the problem? There is a cavity. And then what is this cavity is carrying inside? If some person developed a cavity sometime in his or her life, he had pneumonia at the age of 5 years. The person had pneumonia by the age of 5 years. He remained well onward throughout his life. But during that time he had serious pneumonia. That pneumonia resulted in structural damage. He developed a cavity. So do you expect that that cavity can have something in his future life? That cavity can have calcification. That cavity can have fungal ball. That cavity can get infected. That cavity can get filled with the pus. So he or she can have some problems in his future life. So if you ever see a cavity with this kind of soft opacity, we call them soft shadows. Why we call them soft shadows? Because this shadow is not denser than bone, even not like bone. This is having lesser density than bone. So I would be labeling it as a cavity with a soft shadow inside, whitish haze inside. We label it as aspergilloma. So this is a very good radiological imaging of a patient with aspergilloma. How a patient can present? That patient might be presenting solely with multiple episodes of hemoptysis. This would be coming in with hemoptysis, and the treatment, you just give a symptomatic treatment, and many a time you remove that aspergilloma, only then patient gets better. Move ahead. So cavity in the middle zone of right lung causes include tuberculosis, Klebsiella, fungal infection, embolism, Wagner's, so many things are there. Again, now this is a very, very classical picture of what? This is a cavity filled with a complete fungal ball. And there is air shadow here. Can you see that air shadow? So there is a cavity. Let me just draw it for you again. So you see here, this is black or blue. Let's write down with the blue marker. So you are seeing here, we are about to finish. In next 5 minutes likely we'll finish. So you are seeing here, this is cavity, a thick walled cavity. Then we are seeing another thing. This hole has been filled with something, and that part is unfilled. That is kind of half moon shadow. So can you see it? This is a half moon shadow, a crescent sign. So if you ever see a crescent sign in a cavity, this is known as a crescent sign or a halo in a cavity. This is classical picture of aspergilloma. So remember this thing. Move ahead. Go ahead. Everybody can see, if this patient presents to you in casualty, what you will be doing immediately. I mean, this is all black. This is all jet black. And this jet black thing has pushed the whole mediastinum towards the other side. What it is? This is tension pneumothorax. This is a emergency. This is a medical surgical emergency. Immediate intubation is needed. Otherwise, a patient would be having hemodynamic compromise. He might be at that time having severe hypoxemia. You would do the intubation, patient will get better, right? So these were different sort of slides related to chest X-rays. In the next session, we'll be discussing few more X-rays.